Jennifer Johnson is our first Charles Stewart Mott Endowed Professor of Public Health at Michigan State University's College of Human Medicine. She earned her Bachelor of Science degree in physics and a doctorate in clinical psychology from Brigham Young. She conducts NIH-funded randomized controlled trials to determine the effectiveness and cost-effectiveness of mental health and substance use interventions for vulnerable populations, such as pregnant women, prisoners, and jail detainees. And she is doing that work now in Flint. Her research and implementation science also examines the ways that we can change policies and systems to better support mental health care for vulnerable populations. She's been the principal investigator of 8 NIH awards totaling more than $14 million. Please welcome Jennifer Johnson.
So I've been to and considered joining some of the most prestigious institutions from coast to coast, but I've never seen anything as stunningly brilliant and unique as these public health positions in Flint. The two things that make them unique in my mind were strokes of genius, primarily by Aaron Souza and Jeff Dwyer. The first was the community-based participatory hiring process, in which Flint community members made up a large part of the search committee. They interviewed us, they vetted every one of us, and they're a large part, I think, why all of us came. The second is that the positions are structured and funded in a way that sets us free as faculty members to pursue the science and the research that we feel like is most important for the common good. This is actually very rare. In the first 15 months of this group's existence, our 4 faculty members, in the time we've been here in Flint, have, I believe, been principal investigators of nearly $15 million worth of NIH funding. By summer, it may be $25 million, and this is impressive. We are still a small team, and the public health problems that we are trying to address are very large. Therefore, we're growing. But fortunately, Flint is a fantastic place to be, and I think if we build correctly before I retire, I would love to see a school of public health here in Flint. And I think that we could have 50 to 100 just like us, along with our teams right here. So as a clinical psychologist, I'm both a researcher and a clinician. I'm a big R researcher, but all the work that I do is clinical research. Most of my studies are randomized trials of counseling interventions for mental health and substance use, especially improving relationships to improve those issues. For example, one of my studies helped pregnant substance users reach out to more non-using people who would support their sobriety during pregnancy. However, as I started out in treatment research, I think in general there's this idea that researchers create knowledge and clinicians and policymakers use the knowledge that researchers create. However, this isn't completely the case, because for many public health problems, the knowledge to address them actually already exists. It just isn't used. This is where implementation research comes in. So there's a science of how to get individuals and governments and policy organizations to do what is already known about what works. So let me tell you how I discovered the importance of implementation research and how I weave together these threads of being a clinician, a treatment researcher, and an implementation researcher. In 2012, I published the largest randomized trial of any treatment ever for major depression in an incarcerated population. However, as I was publishing it, I realized, well, I knew from what I'd seen during running the study that the results would never be used in the current system, because the state in which I was working was very well funded, but it only had enough mental health clinicians, not even Ph.D. level clinicians, MSWs and others, to address rape allegations and acute suicide crises. And this was despite the fact that mental health problems are the rule and not the exception in justice settings. So when I thought about that, I asked a lot more questions, and I realized that there aren't providers because there's no money for the providers, and there's no money to hire the providers because the legislatures set the budgets, and the legislatures don't appropriate enough money because they answer to the voters, okay? Turns out that the voters tend not to realize how large our justice system has gotten, that 1 in 34 of their friends and neighbors are justice involved, that 99% of justice involved folks are either in the community or will be back soon, and that our justice system has become so large that you can't address any public health problem in the United States without and ignore this system. So, for example, the 3 largest mental health treatment systems in the entire country are jails. So then in the course of trying to do treatment research, suddenly my research question expands to take in changing the minds and hearts of the entire US electorate. That's implementation research, okay? Let me give you another example. So 10% of all suicides in the entire United States occur in the context of a recent contact with the justice system. So that's 10% of all suicides. So in order to help reduce the overall US suicide rate, I submitted and received a $7 million NIH grant here in Flint last summer that would use the justice system as a catch and release for people at incredibly high risk. So how this works is there are nearly 12 million admissions to jails every year. This is when you're arrested, picked up for a day or two, you may not be charged, you probably won't be convicted, you might be, and then you're released. And so you have a system that has people at very high risk for just a couple days. Well, it turns out that there are interventions in emergency departments that are very effective at reducing suicide in the year after an emergency department visit. They're also cost effective. They reduce suicide by 50 to 90%. So the idea is simply to see if those interventions in the emergency department work in the jails, because it's actually not that different in terms of the length of stay. And if they are as effective in the jails as they were in the emergency departments, we could reduce 5 to 9% of all US suicides simply by doing this simple intervention in the jail. So this sounds fantastic, right? But here were some of the public comments on one of the press releases about the study. Quote, "A total waste of money. Take the money and put it toward preventing all the suicides by veterans. I don't care about prisoners. I care about veterans. Priorities." Quote, "Productive members of society pay to spend millions to study the dregs of society. What a country." So, this is what we're up against. Not to mention that, the veteran liaison told me that 10% of people in our jail here are veterans. Jail detainees are not prisoners. They're not convicted. They're not even criminals because they're not convicted. You're innocent until proven guilty. Advocating for adequate health care is not condoning crime. And this sort of general philosophical problem with providing adequate health care to those that society deems to be less worthy somehow. So, this is one example where we know what to do, but as a society, we have a knee-jerk reaction against following what the science would dictate. This is implementation science. And it's why for treatment research, at least for what I do to matter at all in the real world, I'm doing implementation science as well. So as mentioned before, I'm both 100% researcher and 100% clinician. Here are the 3 most important things I've learned as a mental health counselor. First, when you get people alone and get them to drop their defenses and really talk about their hopes and their dreams and their fears, people are much, much more alike than they are different. We're just really not that different from each other. The second is that listening is 80% of solving a problem. The third is that negotiation of a therapeutic working alliance, which is defined as a mutual understanding of a problem, agreement on goals, agreement on methods to reach the goals, and mutual respect, is one of the best predictors of treatment outcome, of mental health treatment. So how does this inform my research in Flint? Coming into Flint, there is no doctor-patient relationship, right? I come in as an equal, just to start with. Yet, what happens in therapy is still true. We're all more alike than we are different. There's a quote I found actually from some of the community members as I was getting ready to come here that I love, and it says this: "If you've come here to help me, you're wasting our time. But if you've come because your liberation is bound up with mine, then let us work together." So in Flint, as in counseling, listening is at least 80% of solving the problem, really listening and really understanding. In Flint, the collaborative negotiation of a working alliance is also very, very important. So this is agreement on goals, agreement on steps to reach the goals, mutual respect. And the way this works in community engaged research is I come in, I listen to the community's perception of what the problem is, repeat it back until they say that I understand, ask what they've tried, consider what they're thinking of doing, talk about what I potentially have to offer, which may or may not be a good fit, and then we talk until we find something that is a good fit. So that's how this working alliance works. Unfortunately for academics, this is actual fairly radical equality when it comes to working with community partners. Community-based organization partners, CBOP, and our other community partners in Flint have exceptional skill and wisdom and experience. They're our equals, and actually most of the time when I work with them, I feel like they're more than my equal, they're my superior. Unfortunately, because many of these people are from historically marginalized groups, African American women, they're not always heard or respected, I think, the way that they should be. But I would say that researchers and clinicians are unwise if we don't involve representatives from our target populations at every step of the decision-making process, including planning a project, budgeting the project, executing the project, and reporting the results. So to our fantastic, experienced, wise, hardworking, passionate community partners, I'm going to call out a few, but this isn't all. Mrs. Deloney, Janice Muhammad, Sarah Bailey, Yvonne Lewis, Kent Key, Vicki, you're at U of M Flint, but I just love you anyway. You know, and many, many of you who've written grants and papers with us until the wee hours of the morning, 3 and 4 o'clock at night, even though many of them are in their 70s. They stay up all night with us and write. Who've taught my 10-year-old that character is who you are when no one else is looking. Who've attended our job talks and invited us individually and as a group for no other reason than an interest in the greater good. Thank you so much. Thank you for your decades of dedicated service to improve the city where my family and I now live and work and shop and worship and play. I hope you know by now that I will show up for you, that we will show up for you, that we'll fight alongside you, and I know that you'll continue to show up for me and for us. Martin Luther King was fond of saying that the arc of the moral universe is long, but it bends towards justice. Working together, we can help bend it toward justice, equity, prosperity, and recognition of those who've been under-recognized for far too long, who've worked here in Flint for decades to represent their people, who are now also our people. Thank you.
Nobody has one, the mayor has one, and it's a way to keep us together and wherever we're hard to sit.
Thank you so much.